case?
Yes. So secondary frozen shoulder, correct. So secondary frozen shoulder is very important because you have to now treat the rotator cuff tear primarily. So you always remember if there is a, so rotator cuff tear, now we are not discussing it, but I'll just give you a short, rotator cuff tear can either be partial or it can be full. Okay, if it's a partial rotator cuff, then you don't need to really worry about it. You take care of the bursitis which is associated with it. You give them a local intralesional steroid, you reduce the swelling, the patient will already start feeling better. Then you advise him aggressive physiotherapy, he will come back to full range of movement. A full thickness rotator cuff tear has to be operated upon, has to be treated, and then you ask them to do physiotherapy. So the management for a partial and full rotator cuff tear is a little bit different.
Okay. Sir, how much is the effectiveness of ultrasonography helpful in diagnosing the adhesive capsulitis?
So ultrasonography is a tool which is very user dependent. So ultrasonography done by an expert sonologist will give you a good picture and will come to a right diagnosis. And you know, when it comes to MRI, even a surgeon or a clinician can see it for himself. So I don't have to depend on the report. So that is a major difference for me. I mean, if someone is reporting an ultrasound and I can believe his findings, then I can just go ahead.
Okay.
Also, you know, ultrasound is reserved for specific indications, like if the patient has some metal implants inside and he's unable to undergo an MRI, then an ultrasound sonograph, is required, because that is where he can actually have an alternative way of diagnosing the problem.
Sir, all these steroidal injections and all these steroidal medicines, do they have a long-term effect on the health of ligaments of shoulder?
Yeah. So steroid is very important because it should not be misused. So you should always remember, steroid should not be always only given for the treatment part. It can also be used as a good diagnosing tool. So if you give a steroid maximum 1 or 2, you should not try and give steroid again and again. Any intralesional steroid, if there is a requirement to give multiple steroid, that means you're not taking care of the pathology which is inside the shoulder.
Okay.
So steroid given once gives a good result. It means that you have also given a good treatment to the patient and it has helped to confirm the diagnosis. Now if the patient comes 3 months later with relief then but recurrence of symptoms, now you can maximum repeat one steroid, or you can ask him to move to the next step, which is arthroscopic. So do not always insist the patient on giving him steroids again and again. It will not take care of the problem which is inside.
Okay. So in terms of medical or in terms of shoulder pathology, how do you define steroid abuse or overuse?
So number one, never take oral steroids. So for the shoulder, as a shoulder surgeon or as an orthopedic surgeon, I never give any oral steroids to the patient. So never ever give oral steroid to the patient. Number one. Okay. Number two, I've just seen a question, which is a very good question. Are steroid injections safe for diabetic patients? Yes, they are, provided the sugar is under control. So for me, the fasting should be under 140. The postprandial should be under 210. If these are the upper limits, then steroid injections, even in diabetic patients, are definitely helpful. Now, where should you give the steroid injection is very important. So as I had said in my lecture earlier, steroid injections should be given according to the pathology. If the problem is in the biceps, give it in the biceps. If the problem is in the supraspinatus, give it in the supraspinatus. You can't give a steroid anywhere and expect the result to be the same. So the patient, a lot of times patients have come to me saying that they have taken a past injection of steroid, but there was no effect. I have still gone ahead and given them the same injection, but at a different location, and they have completely recovered. Why? Because the pathology was not, diagnosed before giving the injection. So first, find out where the problem is, and then give a focused treatment in that region. Just don't give a subacromial injection of steroid and expect it to work like magic.
Okay. Sir, if the patient presents with secondary frozen shoulder, then treating the root cause and then doing physiotherapy, can the lack of therapy in between worsen the stiffness?
Yes. So physiotherapy, always remember, whenever you see a patient with a stiff shoulder, always advise the patient that if you are starting physiotherapy with me, go the entire way along with it. Like, do not just intermittently stop coming and do it at do it at your own level at home. It should be completely supervised till the entire result is achieved. So whenever a patient comes to you at your clinic, the patient registers to your clinic and then starts the physiotherapy. So always get a confirmation from the patient that you are going to stay with me and I'm going to give you my complete, knowledge
Protocol.
and experience in order to give you a good result, but don't leave it midway. Don't jump to conclusions. It's working, not working. We'll treat it together, but stay with me the entire journey. So never ask the patient to just do it as an intermittent thing. That is very important, because what happens is then they start blaming it on the physiotherapist. That, he or she has started physiotherapy and I'm suddenly not getting any result. I tried my best, but I'm not reaching where I'm supposed to be. Because the problem was not with the physiotherapy. The problem was with the patient itself. They were not quite sincere with their physiotherapy. That's what.
So in terms of communication, what would you require? What do you feel that the bridge between the surgeon and the physiotherapist is there, which we should break or we can break to achieve better results?
So for me, a surgeon or a physiotherapist are working synergistically. So they have to work towards a common cause. They have to be communicating with each other. So it can't just happen that I do a surgery, send the patient, and I expect the physiotherapist to completely take care of the patient. It doesn't work that way. The surgeon should be constantly involved till the physiotherapist is, giving physiotherapy to the patient. So every step of the way, the physiotherapist should be informing the surgeon about the treatment which is happening. you know Overnight movements don't improve. They take some time. The patient may either be compliant, maybe non-compliant. There may be something in the surgery which has happened which needs to be taken care of. The surgeon should be always spoken with. So whenever a patient comes to you post-operative, always talk to the surgeon before you start physiotherapy. There may be some special instructions involved, like for example, a patient with a stiff shoulder, also with a rotator cuff tear, comes to you but does not give you the proper history. Maybe operative notes are not there with the patient. You just assume the patient has a frozen shoulder and then you start doing aggressive physiotherapy. He ends up damaging the rotator cuff repair which is done inside. So
Yeah.
you always talk to the surgeon, know what exactly has been done, and then proceed with the physiotherapy session.
Sir, if frozen shoulder occurs following dislocation of the shoulder, then how to go ahead with it?
Yeah, so that is also another good question. So frozen shoulder will happen after dislocation when? In two cases. One is when the dislocation is still there, like the patient has a neglected dislocation. The patient has not reduced their shoulder and ended up in a frozen shoulder. That is one scenario. Second scenario is some doctors, after reducing the shoulder in a dislocation, immobilize it. So they sort of give them a strapping, give them a complete immobilization, and then ask them to do range of movement. But then the patient is not able to, and then ends up getting a stiff shoulder. So both the cases are different. Now in the first case, we always refer the patient back to the surgeon, ask him to reduce the shoulder, either do it under anesthesia or do it surgically. Bring the shoulder back into position, allow the ligaments to heal, and then do aggressive physiotherapy. In the second scenario, which is the most common scenario, the patient has been advised immobilization for a long time. In that scenario, only avoid abduction, external rotation. So this movement is something we should not ask the patient to do.
Okay.
So if the patient is lifting their arm straight with the arm close to the ear, absolutely straight, there is no probability of a dislocation happening. The patient will be apprehensive because he has just had a dislocation and he's scared about it. But you can always convince the patient that if he's able to keep the elbow perfectly 0 degrees, keep the arm close to the ear and just raise it or try to do physiotherapy in this direction, he'll never get a frozen shoulder. So external rotation perfectly all right in neutral alignment. So if the patient is having external rotation done like this, it will never lead to dislocation. If the patient is doing internal rotation, it will never lead to a dislocation. So what will lead to a dislocation? Abduction, external rotation. This one movement you try and avoid, you'll never have a problem.
Okay. Sir, I think we will take the last question for today. And whatever the questions are left with the audience, we can have a 5-minute sessions early for tomorrow's session or Thursday's session. So
Sure.
we will take the last question for today. Sir, if pain does not decrease even after steroidal injections
Yes.
in diabetes patients and continuous physiotherapy, then what to do?
So then you go ahead, do an MRI. So what normally when a patient presents to me, I have a standard protocol. So number one, diabetic frozen shoulder, refer to the, so I'll just explain my protocol so that everyone just understands how I treat a patient with a stiff shoulder. Number one, patient comes to me, he has a diabetic frozen shoulder, no secondary pathology. I always refer them directly to the physiotherapist. Then I try and call the physiotherapist. I sort out some treatment plan. I sort out some exercise plan and follow up with the patient. Next, the second patient, he comes to me with some secondary pathology. I try and find out the cause of pathology. If I think there's a full thickness tear, I immediately send him to an MRI. Full thickness tear with a history of trauma should be investigated first. I think the patient does not have any sort of trauma, but still has developed painful shoulder. The patient is young age group, under 50 years of age. I would probably think it is a bursitis, partial tear, or a long head of bicep tendonitis. I first give an injection. I don't always advise an MRI to the patient. It's expensive and it will not change my course of treatment. So for me, giving the treatment is more important. So I first give an intralesional steroid. I wait for 2 weeks. The patient most likely recovers. If he does not recover, then I advise an MRI. If he recovers, I then send him to a physiotherapist and ask him to regain the loss of movements which he has had. And if the patient stays completely all right for the next 6 months or 1 year, it's all fine. So when he comes back again to me, I again treat him as a new patient.
Okay. I think, sir, we are done for today. I don't think we have more questions. Now, I have a question from my side. For tomorrow, for next session, what are your expectation? What we should go through and read once?
I mean, what I would like to know is, last time also I had a talk for Ask Physio. So,
Yeah.
On this group, I'm not dealing with any students. I'm dealing with all professionals. I'm
Yes, sir.
dealing with people who have had, their own day-to-day experiences with shoulder patients for a long time. They have had their own protocol set. They have had their own questions in their mind. So I would like to really know that, case to case basis, how do they look at patients and what kind of not just theory, like practically speaking.
Yeah.
Because ultimately we have to get the patient all right. We don't have to write textbooks here.
Okay.
So, we have to deal the problems as they come in the consulting.
Okay. I think, sir, everybody has very much got an idea that what is the surgeon expecting out of clinical physiotherapist. I
Yeah.
think that is good enough for the next session. And I think we will definitely discuss other questions. There might be a lot of doubts in the people's mind, but definitely, I'm sure they will definitely ask all these questions in the next session.
Yeah, I
So,
tried to move around, because it's not that easy, trying and
yes, sir.
explaining frozen shoulder, because my way of looking at frozen shoulder may not be exactly similar to other doctors looking at frozen shoulder. So
Yeah.
frozen shoulder is a very, very, very surgeon and a physiotherapist, personal oriented topic.
Yeah.
So what happens is every person has their own way of looking at it.
It's very
So
subjective.
yeah, it's very subjective. So that is where it's very important to make your own protocol. So I'll always repeat that no matter how much you discuss and all, but always, every patient you see, make your own protocols. Remember, you are as good as any person who is explaining or giving a lecture to you. So not necessarily just because I'm giving a lecture, I have far better knowledge than you. You guys must be having 10 times more knowledge, but just train your own protocols. That will help you in diagnosing the patients next.
Okay. Thank you, sir. With that being said, I think we will just disperse today's session and let's hope
Sure.
the other session is as interesting as today's one. Okay.
Yeah.
Sure.
Thank you
Thank you,
for
sir.
attending the session. Yeah, I hope I was at least able to get 5% of my message.
It was very good lecture, sir. And
Thank you,
definitely
everyone.
we'll see you in the next lecture. Thank you, sir. Thank you for your time.
Thank you, sir.
Thank you.